And good morning. Good morning. Good morning. What am I saying? Good evening, everybody. And welcome to the Maternity and Midwifery Hour. We're now in Series 15 and Session 2. And I'm delighted. I'm delighted to introduce myself as Sue Macdonald, Curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. But I'm also absolutely delighted to be joined by Professor Mary Renfrew, who's going to come on screen any second. There she is. And because we're mean and nasty, we always ask our guests to share a moment of the week with us. So Mary, could you share your moment of the week with us?
Oh, Sue, what a week. You asked for a moment of the week. I think I have to acknowledge this has been quite a week in the US and globally. It would be wrong not to do that, especially for people in healthcare and maternal and newborn health. So I just want to say that there would be many people out there thinking about it. But I did want to tell you about a moment of unbridled joy this week, which for us was an antidote. We're moving into a new home. And every week I look after one of my little granddaughters. I have four, and she is nearly three. So imagine a nearly 3-year-old. And she was looking out the window for pretty well the first time in this new home, and she saw running along the top of the fence, not one, not two, but 3 squirrels. And her face, her whole body, everything expressed boundless joy. And I thought, I have to learn from this. I have to learn. Absolutely. And even in dark times, there's joy in the world to be experienced and felt. So her infectious positivity is something I'm trying to hold on to.
And that's transmitting to all of us. That's lovely, Mary. Thank you so much. Well, we're coming back to Mary now. I'm delighted that Mary's our star guest. We only have one, we only have the best speaker. We have one speaker this evening because she's going to share a huge piece of work. So we'll welcome her back in a moment or two. And I'm just going to, for those of you who are new, and I know we've got some new people with us this evening, and welcome to you. And I'm really delighted that you're able to join us. I know we've got old friends as well, because we often do. And I just wanted to run through really where the maternity midwifery hour came from, which was the lockdown for COVID-19 in 2020. And many of you will remember how scary that was and how much we had to focus on clinical practice. We couldn't go to study days, couldn't go to conferences, festivals, whatever. So we came up with this idea of having an hour a week focused on maternity services, and we were able to invite midwives, student midwives, anybody actually who was interested in maternity services to join us. And initially we focused a lot on COVID-19 because we didn't know a lot about it. And there were also huge changes going on in education and in practice and in management within the maternity services. And it was really helpful, I think, for people to understand what was going on. And we were able to look internationally a little bit too, which was fantastic. But we've carried on because people seem to like coming every week, which is lovely. And I need to also say and remind people who don't know about us that the Maternity and Midwifery Forum record everything. So if you should have a power cut or you get called away, don't panic. You won't miss Mary's fantastic presentation because everything's recorded and you can catch up at a later time. And some of you who are watching this in a few days' time will know that because you're watching it in a few days' time, if that makes sense. And that can be really useful. We're very committed to making sure that wherever you're working, whatever you're doing, you can access continuing professional development. So that's fantastic. Also, for those of you doing revalidation, any projects, for those of you students who are doing assignments or dissertations, there's a huge back catalogue of all sorts of materials. So have a look at Matflix. That's on the resources sheet, as are loads of lovely references that Mary's provided, and lots of links that are very useful to you. We hope they'll be useful to you anyway. So I'm going to also say a big thank you to those of you in the maternity services. And I think because I've been reading this fabulous report of Mary's, it's really reiterated to me how tough it is in the maternity service just now, wherever you are, if you're in UK or you're in Europe or you're in the rest of the world, it's tough. It's a difficult time. And partly because, I mean, there's the usual thing of sickness and flu and colds and things going on, but there's also, of course, we know an international shortage of midwives. So where there's a shortage of midwives, some of us are having to do picking up of other people's work and supporting and carrying on giving quality care. And it's really, for me, I want to say thank you. And it's a special thank you because having read Mary's report, it has real resonance for me about what midwives can do and what midwives want to do in difficult circumstances. And we'll have more on that later. So I'm going to do a quick news flash. We've had RCM Wales have underlined the crucial role of consultant midwives in delivering safe, high quality care. And they're recommending 2 consultants per health board, two consultant midwives, which is great. Also, what caught me on Twitter, and I'm still looking at Twitter, but I'm preferring the blue sky, really, to be honest. But there's a lovely story from West Suffolk Maternity Service where a local artist who's called Sarah Marie has been painting a mural in the maternity service for mums and midwives to use. It lifts the spirits, and it's something to have photograph your new baby and mum and partner and everything with. So I thought that was really nice. And there's also a new community app for Black mums developed by the Motherhood Group to help Black mums link with other Black mums, mums link with mums, which is fantastic. So there's a link on that to the other resources as well. Right, I've gallopy, and I'm now going to come back to what we're going to do this evening. Well, we're looking at the independent report on enabling safe, quality midwifery services in care in Northern Ireland. And this included a careful examination of midwifery and maternity care, and that followed a concern about safety of care. And it really is the first report to take a whole system perspective and draw on evidence. Well, of course, we're talking Mary Renfrew. It would have evidence at the core at all times. It's obviously got recommendations and key conditions for safe quality midwifery care and recommendations for transferring maternity and newborn care. And therefore, I'm delighted to introduce Professor Mary Renfrew, OBE, Professor Emerita, University of Dundee, the author of the report. And I think everybody will know Mary's work early on in the breastfeeding, infant feeding, maternal infant health, and as well as the landmark Lancet report into midwifery. Also, the future midwife within the UK, and that's all underpinning. I have to, now where have I put it? Somewhere here. Underpinning the Nursing Midwifery Council standards of proficiency for midwives, which is also on your resource sheet. I also included the Lancet report for those of you who might not know about it. It's really a very useful document for you. So welcome, Mary. Thank you so much for coming this evening to share your knowledge, experience, and all this lovely report. The screen is now yours. Well,
Thanks so much, Sue, for that great introduction. And I'm really delighted to be with you all tonight. Thank you very much for taking the time this evening, or whatever time zone you're in this morning, this afternoon, even this night. Lovely to have you all here. In May 2023, I was commissioned by the Department of Health in Northern Ireland to conduct an independent report. It was in response to concerns about safety of midwifery services, specifically in Northern Ireland. A coroner's report following the death of a baby raised specific concerns about care in freestanding midwifery-led units, and there were wider concerns about safety of midwifery and indeed wider maternity services. The report that Sue's just been telling you about was published in October 2024. It still feels very new. We're really just now talking about it and working on disseminating it to all the places that matter. It was immediately positively received by the Government of Northern Ireland, which has committed to implementing the recommendations, which is amazing. And as Sue said a minute ago, it's the first report on maternity services in the UK to examine a whole health system and to specifically use an evidence-informed analysis to identify solutions. So what I'm going to do this evening is tell you about the report and draw out towards the end some of the lessons that might apply more widely across the UK and beyond. Before I get into the details of the report, I just wanted to take a moment to step back and think about the wider context of this work. You will know better than I do the current environment for maternal and newborn care across the UK particularly, more widely as well, but tonight we're really focusing on what's happening across the UK. And it challenges all of us to think hard about what matters for women, for babies, for families. We hear criticism of the maternity services on an almost daily basis. The social, the cultural, the clinical contexts of maternity care, women's views and expectations, and the pressure on the health service and on health service staff, they're all unprecedented. I qualified as a midwife, I hate to tell you, in 1978, haha. That's a long time. I have never seen in that time conditions in the kind of perfect storm they are at the moment. The other thing that we're all experiencing is the public discourse around maternity care, and especially around midwifery, is really negative. But here's some questions for you. What should the care of women, babies, partners, and families be at this most formative of times for babies at their birth, for women as they're going through pregnancy, and for the beginnings of families? Is the current model of care working? Are the very high rates of interventions appropriate? How do we decide what's right and what's wrong in the provision of care and services? In this work, I've had to grapple every day with those essential questions and more. It's been hard. I will tell you that, almost impossibly hard at times. But midwives are working almost impossibly hard every day of their lives at the moment. I know that. And there were wonderful, talented people working with me, women and their families, midwives and interdisciplinary colleagues who all rose to the challenge. They all needed the answer, and never for a single second did any of us think it wasn't worth doing this report and doing it as well as we possibly could. I'm going to take you now, after that little thought about the wider context, I'm going to take you into the context of Northern Ireland. There was a coroner's report, I've just mentioned it. A baby died as a result of shoulder dystocia that happened in a freestanding midwifery-led unit. And the coroner's report required a review that looked at these first two terms of reference. One was a comprehensive review of staff experience and training and policies for freestanding midwifery-led units. And then second to that, we needed guidance to all the trusts regarding the management of raised maternal BMI and shoulder dystocia, those being the issues around this baby's death that the coroner was concerned with. On top of that, the Department of Health added a third term of reference in the recognition that midwifery services don't stand alone and that you cannot look at them in isolation from the wider maternity services. So I was asked to undertake further work to inform a consistent approach to the provision of midwifery services, including integration across the wider maternity services. Now that took us right out into looking at the whole system, right across the whole piece. We reworded that and reworked that a little bit into our overarching aim to identify the key conditions for safe quality midwifery services in all settings in Northern Ireland. with this, if you like, mission statement that evidence-informed, equitable, safe, respectful, and compassionate midwifery care should be available for all women and newborn infants wherever and whenever care takes place. So that was what we were aiming to examine. This is the context into which this work was happening. Northern Ireland has the highest proportion of people living in the most deprived quintile in the UK. So although there is deprivation across the UK now, Northern Ireland has that highest proportion in the most deprived quintile. That is quite a challenge. And of course, poverty has been getting worse and still worsening. And so that is definitely a critical context for this work. Northern Ireland has a legacy of political instability. Indeed, at the point at which I started this work, there was no government in place. It had been running for about 2 years without a government. And that had an adverse impact on the funding of public services. The government came into place a few months after I started the work, and since then they have been very supportive. There's been no maternity strategy in place since 2018, in large part because of the lack of government, but also the lack of funding to support that work. Like everywhere across the UK and indeed other countries, the complexity of maternity care is affected by increasing rates of poverty and rates of disease such as diabetes and obesity. Long-standing workforce shortages, especially midwives, will be news to nobody out there tonight, I imagine, but very acute in Northern Ireland. There's about 20,000 babies born annually, almost all in hospitals across the 5 health and social care trusts. There are 5 small alongside midwifery units. There were 3 freestanding midwifery units, but they were all closed as a result of the concern about their safety. Partly they closed in COVID and then didn't reopen, if you like, because of concerns about safety. Until this work was finished, that was the agreement. It's important to start any investigation by looking at what's happening to maternal mortality, to stillbirth, neonatal, perinatal mortality. Maternal mortality, as you know, has been ticking up gradually. Now, we do not have maternal mortality figures for the individual countries across the UK because the numbers are thankfully so small that they're not presented in that way. But this is the stillbirth, neonatal and perinatal mortality rates for the UK and for all of the countries. If you just look at Northern Ireland for a moment, what you will see is that those rates are higher than other UK countries. They are all ticking up. And that's one of the problems that we have right across the UK, is the fact that for all of us, the stillbirth perinatal mortality rates are rising pretty well for the first time in a very long time. Induction of labour rates, again, colleagues in the rest of UK will recognise that these rates have been rising over the years. Here I'm doing it from 2013. The orange bar at the top here is Northern Ireland. The rates are up there. And as a comparison, we've got the dark blue bar in England and the turquoise bar, which is the US, which we have often thought is the benchmark of highly medicalised care. But at the moment, rates of induction are higher. And they look here like they've plateaued out a bit, but they have been rising steadily. These are the data for caesarean birth rates. And what I've got here at the bottom is the OECD average. Now, that is the average of countries that are economically similar to the UK. And if you look at the green line here, that is the US. So bunched up here, we have the UK countries all really, really increasing. There's a dramatic increase from 2014 on up. And only because we've got the 23 data for a further year, it looks as if Northern Ireland is ahead of the pack. But if you look at the year where we have data for everybody in 2022, it's all pretty similar. What we're hearing from individual hospitals now, from Northern Ireland and others, is the rates are heading well on up from that. The rate of increase has not slowed. It's totally unprecedented. We've never seen anything like that. And indeed, the UK is extraordinary in this, in that I believe it's the only country in the world where the rates are as high as this, and there is universal professional midwifery. It's quite a combination. So what did we do in this report when I was asked to do this? The first thing I wanted to do was establish a number of core guiding principles, if you like, for the work. I've put them all out here. I'm not going to talk you through all of them. I just want you to register that we had absolutely grounded in guiding principles with a core focus on the needs and views of all women. And that basically is a human rights approach looking at equity, leaving nobody behind, all women, newborn infants and families, evidence-based, collaboration and participation, a whole system approach, and noting that safety parameters should include physical, psychological, social and cultural safety. And that should be for women, babies, partners and families, and of course for staff and students as well. We developed a novel methodology. There wasn't really a methodology for conducting a review like this. We had to design it. And I had fantastic support from our expert group in terms of designing this. Now, our expert group, I don't know, some of you may be out there tonight. If so, huge thanks to all of you. It was a group of UK and Canadian researchers, expert practitioners and educators and service user advocates with extensive experience and really helped to design this methodology. So it was 6 steps. We clarified all our principles, our approach, our definitions, our methods, and designed it. We established our expert group I've just mentioned, and our advisory group. Again, some of you may be out there tonight who were senior Northern Ireland colleagues right across the disciplines, and of course, service user advocacy input as well. And they met throughout and were fantastically helpful, as well as fantastically challenging. It was not an easy ride, let me tell you, at any point of this. We then examined the evidence with the help of the expert group. We conducted 8 rapid systematic reviews, examined data, looked at information and policy context. Lots of engagement, participation, hundreds of women, partners, staff of all sorts, midwives, students, interdisciplinary colleagues, senior colleagues, policymakers, managers, decision makers of all sorts, and all the organisations involved in maternity care, because of course it's a hugely complex business. You've got the regulators, you've got the Public Health Agency, you've got educators, you've got the university, you've got all sorts of organisations involved in maternity care and the way it works. So that all happened throughout. We wanted to look not only at problems and failure, but also to identify positive service developments, because we wanted to take a strengths-based approach. I don't know how anybody knows how to do the right thing if you don't see the right thing. How do you learn what's right? You can't learn what's right from only looking at what's wrong. And so we wanted to identify positive service developments, which we did across Northern Ireland and the rest of the UK, and one from Spain. We then analysed and synthesised all of that in a structured process I'm about to show you, And out of that, and with continued input and discussion, we evolved the recommendations. I think my point to this method and methodology, and the reason I'm taking time to explain it, is it was novel. It hasn't been done in this way before, and we wanted absolutely everything to be transparent. So when you look at the recommendations, you can see where they come from. They map back to the analysis very directly and in detail. So if you want to know why something's being recommended, you can go back and read the basis for it. We did this systematic analysis using evidence-based concepts. Now that's a great phrase, but what does that mean? What we wanted to do was interrogate what we were finding from the engagement and participation, from the evidence base, from the data, from everything that we were gathering from all of the sources we gathered the information from. And so we set up two sets of concepts. One set of concepts was around quality maternal and newborn care. Anybody who knows the QMNC framework from the Lancet will not be surprised by this. But the other was around how a health system should work. So we went through two sets of questions. And here are the quality maternal and newborn care concepts. We asked these questions of all of the evidence that we gathered from all of those sources. And again, tonight, I don't have time to go into each of them, but are women, babies, and families the focus of care and services? Are they receiving safe quality care across the whole continuum of care? Are they receiving the universal care they need, as well as the additional care they need if they have complexities? Is there a shared culture, shared values and philosophy that strengthens women's own capabilities? So those kinds of questions, we interrogated our findings and addressed and answered each one of those individual questions. Was the answer a no? Was the answer a yes? What was it? And what did the evidence have to say to each of these questions? But of course, care is only one aspect of what's needed to run a healthy maternity service. You need the whole system to work. And so we did a systematic review. The wonderful Christina Mattison led that from Ontario. And we came out with the key concepts for running a quality, safe health system for women and babies. And these were then the concepts that we then interrogated again. And again, you can read those yourselves: political will and policy direction for a quality service, consistent standards, policy and practice based on all the best evidence. One of those concepts is universal whole continuum knowledgeable skilled midwifery, and it's right in there at the heart of the health system concepts, and I'm coming back to that. There's then all the governance issues, capacity building for research, and education, training and staff development. We weren't only looking at practice, because of course practice has to be grounded in evidence, in policy, in education, in training. So we looked at all of those things. That really is why the report is quite so long. The one thing everybody says to me when they say, oh, we've seen your report out, it's very long, isn't it? Yes, it is. And it is very deliberate because we had to do all of that work. What did we find? So I'm going to summarize on a graph for you at the moment, and I'm going to kind of unpick it backwards, and you'll see why. There's a lot of there's a lot to read in this report about what we found, but I've just summarized here, because what we were aiming for was to identify the root causes of the problems, not only the description of what was happening, but what was underlying it. And that's why I'm unpicking this backwards, because first of all, I'll tell you what was happening. For women, babies, and families, we found things that would not surprise you if you've read the other reports from England. We found serious deficits in care. We found trauma and distress, physical and psychological damage for women and babies. We found 3 particular deficits in care. One was for women in pregnancy, where they were getting very little care, support, information, discussion about evidence, about options, about what they wanted, about their own particular care. The second was in late pregnancy into early labour around induction. And it was a real problem for women. It was a real problem for the service. The numbers of women coming in for induction were very high, and the service couldn't meet their needs. And women were sometimes waiting for days after the first part of their induction before they got on through and into labour. Some of them were being sent home. Very stressful, very difficult for women and their families. And the third serious deficit in care was in postnatal care. Now, partly that was because the postnatal staff kept getting pulled through to labour ward, but partly it was also because the caesarean section rate was so high, with 40% of women on the postnatal ward being immediately post-major surgery. Very, very difficult indeed, and it's not something that's been discussed nearly enough, with the potential for both physical and psychological problem, as well as looking after the baby's health and well-being. A lack of equity I have here, persistent inequalities, a long-term impact on early years, women's health and well-being, and population health and well-being. So that's a very, very brief look at the issues. There were many more issues than that. But what was going on for the staff? What the staff were reporting, and this was midwives, this was interdisciplinary colleagues of all sorts, and students, all described very similar things from different perspectives. That the whole ethos of maternity care had turned into a task focus, very limited time for support of women, giving information, and prevention really neglected, lack of personalised care. The model of care, which was this task focus, high intervention model, had developed piecemeal and actually didn't really relate to the guidance once you started comparing it to NICE guidance. Ineffective response to escalation and to adverse incidents. Often that was because people were already too busy and too stressed. A lack of interdisciplinary discussion, planning and review. So there wasn't really a strategic overview of what was happening. Staff and student stress, distress, and of course retention problems, as well as absentee problems. So why was that happening? Where did that come from? Once you tracked it back, it came from a number of factors that related to how the system was working. Right through the system, we were finding that maternity was not a priority. It was a small specialty, so people said, compared to some of the bigger areas of healthcare. I'm never quite sure how maternity is seen as a small area, given that women and babies and families and all of that are all needing care. Fragmentation of care provision, real lack of continuity. And I have to say Northern Ireland has tried really hard to bring in continuity of midwifery care. It's a real policy agenda, but still care was very fragmented. Fragmentation of accountability. It was just very striking that it was very hard throughout the maternal journey to find who was accountable for what. Long-term workforce shortages, especially of midwives, silo working for professions, silo working for settings. And in relation to the coroner's report I mentioned earlier, that hospital, different bits of the hospital, out of hospital, if the midwifery units, and home, very separate from each other, not joined up. Funding constraints, of course, safety focused on hospital and on birth, and that's about what I've just said. There wasn't really any safety work going on much in postnatal, and there wasn't much safety work, if any, going on in the the community units or related to home birth. Limited monitoring and evaluation and availability of data. A culture of fear and blame that was mentioned by women, by all staff, by students. No consistent strategic direction, limited CPD, and that CPD was not related to what the staff needed to know. No opportunity for participation of women, families and staff in the design and delivery of services, and a disregard of the long-term impact. So if you then look at that forward, you can kind of see where we need to intervene. We don't need to really pause to think these are the things that need to be tackling the health system issues so that life becomes better for the staff who really, the vast majority of whom were absolutely dedicated and wanted to do the right thing. And they just needed the conditions in which to do it. And that then would result in much, much better care and outcomes for women. We analysed the positive services. We had 15 examples from across Northern Ireland, the rest of the UK, and one from Spain. And we looked at what was making them work. And we took out these characteristics. And it was the combination of partnership working with women and families, a shared focus, values, philosophy, vision, and culture, ensuring evidence-based care and standards, enabling and supporting midwifery care and services, and positive interdisciplinary team working and education at all levels of the system. So that brings us through to what we then said. What should services look like? Now, I'm not going to give you the absolute breakdown here on midwifery units and home births in answer to the coroner's question, but also to say, what should safe quality care look like out of hospital? We've been very detailed about that, and you can read that in the report. It's incredibly important. What I do want to draw your attention to is what we then outlined as the key conditions for maternity and newborn care in all settings, every setting in which women and babies need care across their whole maternity journey. So we have summarized this in this diagram here, which is, if you like, a sister diagram to the Quality Maternal Newborn Care Framework from the Lancet. This is a quality maternal and newborn health system, and we've brought 7 key conditions. The first one of which is the focus on women, babies, families, and communities at every point in whatever part of the system is working. Starting up here at 12 o'clock at the top, you've got meaningful participation. Women, babies, families, communities, and staff. Now that means they have to be embedded into decision-making forums throughout so that their views are actually making a difference. Integrating standards, services, and education across the continuum of care, the whole continuum, pregnancy right through to postnatal, all disciplines and settings. An enabling environment and psychological safety for all staff and students with respect and shared values. Down here is one that surprises some people, but I don't guess will surprise most of you out there. Fundamental to this health system working, the quality maternal and newborn health system working, is whole system support for universal, accountable, quality midwifery. Of course, interdisciplinary colleagues matter hugely. Every day they matter to women and babies. But if you don't have midwifery that's safe and available and accessible for women, things fall apart. Midwives are the glue in the system. They are the people who are there for prevention. They're there for support. They're there for right through the whole journey for both the mother and the baby. And without them, if you weaken that, the system is weakened. Around here, we've got structures, processes, and resources for evidence-informed planning, monitoring, governance, and commissioning. Absolutely critical to get that aligned with the needs of the system. And then, of course, political will, evidence-informed policy directions for safe, quality, equitable, sustainable system. That, we're saying, should be what a system looks like wherever it occurs. Now that's a system level view. This is the same concept, but from the woman's point of view. And so it's about the whole maternity journey. Round the outside, you've got those essential conditions I just showed you. But this is the woman who ends up with her baby. We hope, of course, there will be some women who encounter loss in that. And they, of course, are critically important through this whole journey as well. But they start in the family and community. They go through early pregnancy, labor and birth, through their whole journey, postpartum, back into the arms of their family and community. And this is where the health service has to get these key conditions absolutely right with these qualities. Now, these qualities were absolutely brought to us by women and staff themselves. The service has to be imbued with respect, kindness, trust, relationship, continuity, prevention, support, and evidence. Women wanted evidence as well as staff wanting evidence. They wanted to know why they were being advised to have an induction, to have a section, they wanted to know why, they wanted to understand. So I know I've only got a couple of minutes left, but what I wanted to say is we then have moved from evidence to action. And we're talking now about transforming maternity and newborn care and services. We're not talking about individual recommendations. We're talking about a transformative implementation plan. There were 32 recommendations. I've summarized here what we're asking for, 3 essential components. To get safe, equitable, quality care and services, we need a reconfigured relationship with women, families, and communities. This is not lip service. This is actually about women and service user advocates being right in the design, the planning, and the assessment, the monitoring of services. Absolutely there. And when women are being cared for individually, that they are treated in a different way with respect for their own situation and personalized care, if you like, but it's much more than that as well. Over here, we have the enabling environment for all staff and students in all settings, and that brings in education, support, a shift in culture. And over here, we have better informed, better implemented commissioning and governance, where the commissioning actually fits the needs of the service and the governance fits the needs of the service. Okay, now I know it's late at night for some of you, and I know this is a bit of a blinder. Don't try and read the small print. This is the summary of the detailed recommendations for system transformation. I wanted this to be a midwife's wheel. So if you think it looks a bit familiar, that's because it's meant to. What we've got around the outside here are the components of the changes that matter. Regional strategic developments, they need to be consistent, they need to be grounded in evidence, they need to be collaborative across the 5 trusts so that women are getting consistent care everywhere. Round here in the orange bit, we've got safe quality care and services in all settings. So that's about home birth, that's about midwifery-led units, and that's that we're now calling community midwifery units, and that's about hospital. And then building for the future, capacity building. So you can read in the report what each of those is, but those are the sort of chunks that we went into. I don't need to tell you why this matters. This matters for every single woman, every baby, every partner, every family. Nobody is untouched by maternity care. And for the baby, it's the beginning of a whole new human being. It is the beginning, if you like, of the population. Over time, every person goes through this system. And that's there for short, medium, and long-term impact. And we forget that at our peril. Physical and psychological and emotional. What's happening next in Northern Ireland is the recommendations have been accepted by the Department of Health with 2 caveats around timing for 2 recommendations. The overall aim is the development of a regional maternity improvement plan as a blueprint for the maternity and neonatal services. Collaborative working has already started. They jumped straight in to doing that. I'm hoping that you're going to talk to me about the learning for the rest of the UK, about what in this is resonating with the other UK countries. Because I think it's really important that lessons are learned for safe quality care for everybody right across the maternity journey. I've spent my career working in England and in Scotland, as well as this work in Northern Ireland. I haven't had the pleasure of working in Wales, but I know from Welsh colleagues that there are real resonances there. And I believe there are also resonances out across the world. I've done enough work internationally to absolutely recognise those. I'm about to show you very quickly a couple of slides of some of the lessons that I think are there for other countries. But while I'm doing that, I'd like you to be thinking of the comments you want to send in, because I would like to hear what you think the resonances are for the rest of the UK. I'm just going to remind you that that is actually, if you like, what we would be aiming for in any health system, is that journey for women right across their continuum. Loads of words on here. Take a photograph of this, do what you like with it. But these, for me, are examples of learning for the rest of the UK. And this first slide is about what are the lessons for reviewing care and services. I'm not going to pause on it, so do take a photograph and have a think about it later. But I think there are important issues here for how one reviews care and services if you're thinking of that in your own area or if there's reviews going on in other areas. And then I've got some examples that are about lessons for implementing change into practice that we're going to provide all women, all babies with the best, safest quality care at all times. These are some of the issues that I think need to be thought about everywhere. So I'll come back to these two slides, but I wanted to say a huge thank you to absolutely everybody who participated in this, and particularly the women who found it very difficult to do. We worked really hard not to re-traumatize women when we spoke to them in this, but there were women who'd had very difficult experience who wanted no one else ever to encounter that experience again. And I just want to acknowledge and thank them for that. We also had women who had great joyous experiences, and they wanted every woman and every family to have the experience they had, and we heard their voices too. Thank you very much for listening to me tonight. I really appreciate it.
And thank you so much, Mary. That was fabulous. I don't know how you managed to condense the overview into such a short time, really. And I would commend our audience. On the reference list, you'll see there's a short summary version, and then there's the full version. Now, you might not want to copy the whole thing out in a printer, but it's all online. Excellent reading. And what I really like the way you finished, Mary, because I think knowing that women, it's very powerful. Women really remember their whole experience, and if it's been bad or difficult, it is traumatic. And what I found when I was reading it, that you get that the commitment of women to want to improve and contribute to helping future women, but also it was balanced really beautifully with the kind of the women who said that their midwives were wonderful and they'd made a difference and they'd helped them make choices and move on, and also the midwives, what midwives were saying. So it's well worth reading this report. Have a look at the short version, but do look at the long version, because that gives the whole complexity of the whole story. The summary is fab, but the big report is fabulouser, if that makes sense. And thank you so much, Mary, for sharing that with us. Now, we do have sometime now. I'm looking away, so I beg your pardon if I'm moving away a little bit, but the questions and comments come on my other screen. So I have a comment from Dr. Maria Heron, who says, As an advocate for better maternity services, I would like to see midwives and mothers working closer together to ensure that the system is fit for purpose. And if Mary, you want to say anything to that, I should think that's close to your heart too.
Absolutely. And what I'd add to that is at all levels of the system, one of our recommendations is for senior midwives to actually be present at board level discussions and for women's advocates to be present at board level discussions. So what I'm saying is right through the structures, we want women and midwives to be talking with each other, but to be talking with everybody else as well.
And the women's voices to be as loud as possible within the whole trust.
Women's voices to be embedded in all the forums right through the trust.
Fabulous. Thank you, Mary. And I've got Rachel Tolley. Hi, Rachel, who says, I'd be really interested to hear if COVID was included as a complicating factor within your review and findings, and how or if it impacted on your findings review, and if you needed to adjust your terms of reference. Fantastic to see such a system focused approach, to this review with consideration of human factors and not a root cause analysis approach. So Mary.
Thanks, Rachel. That's a really important question. This work was started in May 23. Is that right? Yes, May 23. Sorry, because we've just crossed into a new year. I got a bit confused. And COVID had been a factor, but at the time that we were doing the work, most of the women and babies we were talking to were quite new. And for them, they hadn't really been cared for in a COVID affected system in the same way. And it wasn't really something that came out. It was something that a few women contacted me to talk about. And it was certainly something that the staff talked about because they were all still scarred by the experience. And in fact, the COVID inquiry was going on in Northern Ireland at the time that this work was happening. So the senior policy colleagues I was working with kept disappearing off to go and give evidence to the COVID inquiry. It was very much in the air. And what I've said is that the impact of COVID was still rippling through the system. And simple things like there was much less home visiting by midwives because they'd replaced some of those home visits with virtual consultations.
Mm.
And that had happened in COVID and had never quite got unstuck again. And some women found that very hard. Others liked it, but for some it wasn't what they wanted. So simple things like that, as well as the longer term impact of exhaustion for the staff. But it wasn't a big issue. It was clearly a background factor that had been an issue.
Lovely. Thank you, Mary. I think I've got continued. I think this is Dr. Maria Heron. Hi, Maria, who's saying continued excellent and brave research. I hope the findings will be taken seriously. I think so. And then we have Kate Frith. Hi, Kate, who says, question for Mary, what do you call your methodology? Did you name it?
No, we didn't, but maybe we should. We do want to publish it. We do want to publish this report in a peer-reviewed journal, and we definitely want to describe the methodology. I'll have to think about that. Thank you. Good idea. Yeah.
Kate set you some homework, Mary.
They have. And if anybody, any suggestions, please send them in.
All right, okay. So we might get a little ripple of those. And Sarah says, what were the demographics of the women and families?
What a great question. And I wish I'd had time to tell you about that in detail. Let me give it to you in summary. We wanted to talk to all sorts of women. We wanted to talk to women right across the demographic and ethnic diverse mix. We also wanted to talk to women who had mainstream experiences. We were not focusing hugely on the very traumatic end of the spectrum. We wanted women who'd had every kind of experience. And so the way in which we recruited women to talk to us was through existing community groups. We wanted to talk with women who might be a whole cross section. So breastfeeding support groups or mums and tots groups or Sure Start groups. Northern Ireland still has Sure Starts, and they were a great source of support for us in this. And so they weren't self-selected in that way. They gave us permission to come to their group, talk to them, and then we made sure that the group organisers supported them afterwards. So we didn't talk to them and then leave them. And of course, they supported each other. There was then peer support going on as well. We didn't use social media to recruit them because we didn't want to re-traumatize anybody out there who might come across this. So we had a huge cross section from the most deprived through to women who, were not deprived. But I would say on balance, actually, because of the makeup of Northern Ireland community, that many of them came from backgrounds of deprivation. We had a range of ethnic input. Having said that, Northern Ireland has very low ethnic diversity, somewhere around 4% at the moment, growing. But we did work with community groups who were working with the Chinese community, with the East Timor community, with asylum seekers and refugees. So we tried to cover those bases.
Fabulous, thank you. Okay, well, Kate Frith is adding now and is making a comment. Hi, Kate. It says, having returned to midwifery recently, I'm surprised at how disjointed our maternity services are. I feel that there's no room for relationship building with women and families, which makes it easier to make safer decisions for them. That's a good comment. Thank you, Kate. And then we have Gillian Ferguson. Hi, Gillian, who says, as someone who's in my 3rd trimester with firstborn in Northern Ireland, unfortunately, I resonate with a lot of the lack of information and meaningful contact with midwives. I would wholly support women's voices being embedded, as currently this feels ignored.
Well,
thank you, Gillian. That's wonderful.
Gillian, that's really helpful, and I hope everything goes well for you.
Yeah, we'll be sending positive vibes to you, Gillian. Thank you. And then, was there any? This is Rachel. I think Rachel Tolley is asking, was there any inclusion engagement from primary care in your review?
There was, in that we talked with the RCGP. It wasn't huge because we didn't get a whole lot of GPs coming to talk to us, but we did have some very active engagement from a small number, which was almost better than having limited engagement from bigger numbers. So we did get, we absolutely got that. And it's one of the disjunctions and one of the accountability issues, actually, raised by GPs, is that when women are discharged home after cesarean section from the hospital, but perhaps with inadequate pain relief, and perhaps within a day or two of having a section, and therefore needing care, concerns about infection, blood loss, all the rest of it, who is accountable for that? And it's got us into a really, really interesting conversation about post-surgical accountability, which is unlike any other area of surgery. And one can argue, and I can argue, that midwives are taking delegated responsibility from the surgeons and indeed the anaesthetists for pain relief up to a point. But if there aren't enough midwives to do that, then where is that accountability sitting? I think the GPs got us into really, really interesting conversations because they felt uninformed about what had happened to the women in hospital, and unprepared for that responsibility. But there was no follow through from the hospital. Women could go back into hospital if they needed, but they didn't always know they needed to go back in. And there needed to be a level of community oversight and accountability that was not joined up.
More disjointed. Okay, thank you. And we've got, thank you for that, Rachel. That was a really good question to ask. And then Jenny Hall, hi Jenny, says, such an important research report. Thank you, Mary. The induction and cesarean section rates are shocking. Midwifery is pilloried in the press. So where are in the other countries of the UK do we start, as there's so much to do to change? Small question then, Mary.
I think there's a number of steps. For me, one of the most fundamental has been finding on the way through this work that there are solutions, that can work. I think it's quite easy to get really disheartened. I know that. Any of you out there feeling disheartened right now, you're not alone, but there really are solutions that can work. And what we absolutely have to do is work very closely, hand in hand with women, with advocacy groups, with families, to bring in public health into this arena, because public health has got such an important role to play here, and yet they're being sidelined in the whole maternity debate because there are all sorts of important issues and different ways of seeing maternity safety that is not just about that very focused moment around labour and birth, that is much wider than that, that brings in prevention, that brings in support, that brings in information. And it's getting that message through with women, to women, and hopefully out through the media. But there's an important intermediary step, which is our professional colleagues have to hear that and understand that. I think there's really important lessons for the Royal Colleges. There's really important lessons for several organisations, the CQC, for example. One of the things that was most heartening was how completely brilliant the students were. There's one provider of midwifery education in Northern Ireland, and that's Queen's University. They were very, very involved in this work. Jenny McNeil, who's a reader at Queen's, was my right hand through the whole process. And educators and students were very involved in the consultation and engagement in various ways. The students were phenomenal, and the newly qualified midwives were phenomenal. And I do think that there is a whole cadre of youth and exuberance and commitment and knowledge coming through. I think they have benefited from the new proficiencies. I think they are absolutely fluent in what midwifery is and what it should be and what it can be. And I think we should be using them to help both in the professional and public forums to get out there and, you know, tell us what it's like, tell us what it should be like.
Ah, fab. And there's another advert for the proficiencies. Fabulous. That's lovely. I mean, that's lovely to hear, because it's lovely to hear the enthusiasm and exuberance at a time when some people are feeling quite low. And I think maybe we need to harness that with us, each other, and as you've said. Thank you for
Hugely,
that.
they need supported, Sue. Hugely, they need support.
Absolutely.
Cannot
Absolutely.
lose.
Well, because I think one of the other things that hit me was students. Actually, in that report, you said there's a comment. Students also reported the midwives were passionate about teaching and supporting students. So I mean, all these lovely things coming through, as well as the not so good. It's kind of getting that balance, isn't it? Okay, I've only got a couple of moments now, because as I always say, this is the shortest hour in the whole week. And thank you for everyone who's putting forward their comments and questions. Now, Patricia Lubeck says, what a brilliant report, particularly considering the complexity of the task at hand. It's so considerate of everyone involved. I wonder if you feel optimistic that in the future, birth can feel safe again for mothers and staff. And that's a lovely question to ask.
I have to believe that that will be the case, Patricia. I have to believe that. We all have to believe that. Once we stop believing that, it won't happen. We absolutely have to believe that the birth environment will again shift and change. It's shifted and changed. I've seen shifts and changes over the last many decades. We have to take it from where it currently is, right at the lowest point I think we've possibly ever seen. The thing about that lowest point, though, is it coexists with an immense richness of knowledge. You know, we have better evidence than we've ever had. We have an education environment that is fantastic. We have a caliber of student coming in, a newly qualified midwife coming in, that I think is really high. We have phenomenally committed and dedicated midwives. I mean, I cannot tell you how impressed I was with the caliber and the input of the midwives, and indeed interdisciplinary colleagues who were very generous with describing what it felt like for them. And I can tell you it's not any easier than it is for midwives. Obstetricians, anaesthetists, neonatologists. It's really important that we all hold together here and work together to counter this negative discourse that somehow has become very personalized, very focused in unhelpful ways, instead of taking the big step back and saying, right, what do women and babies, all women, all babies, all partners, all families need to keep them safe? And what they need, you know, we know what they need. And that's why it's so hard to feel we're at a really hard point, because we really know what they need. We have a richness of resource now that I think, you know, is so valuable.
Fabulous, thank you. And we've got, okay, one question. This, I think, will have to be our last question, though we've got a comment from Victor. Can I ask if Mary was aware of the dedicated induction of labour service providing support, advocating for women, providing individualised services for women?
In somewhere particular, Victor?
I'm not sure. It's just, can I ask if Mary was aware of a dedicated?
Of any
I know
dedicated.
there are some in some units. I'm not sure about Northern Ireland.
Some units are definitely working around that. They are.
Yeah.
I did not encounter that in Northern Ireland. People were trying, but it just, I mean, there's such a mismatch between the current staffing levels and the current model of care. They don't match. There's an intense pressure on the staff, particularly around the cesarean section rates, where cesarean sections are just running, you know, all through the day. The inductions are coming in, and the staff are just getting pulled inevitably into working in situations that just, where there aren't nearly enough staff for that model of care. There's a huge need to evaluate the current model of care, because nobody designed this model of care, let's be clear. It has evolved piecemeal. Nobody has sat down and said, this is what our system should look like. It's ended up here, and it's not supported by staffing. It doesn't fit the current staffing model calculations that are done. It needs evaluated, and it's clearly not improving the mortality rates. There doesn't seem to be a relationship between the current model of care and improvements. So that needs serious evaluation.
And I think it's really good you've emphasised that, Mary, that it wasn't ever designed to be like that. Because when you're in it, you can feel as though it's sort of, well, you feel as though you're in a treadmill, don't you? Just keeping going and being pushed from pillar to post. So I think that's a really useful kind of emphasis. I almost want that to be the last word. But I've got a comment from Maria Heron again. And she's saying, delighted to let you know that we're setting up a campaign group via the Waterside Women's Centre in Derry for mothers, midwives and advocates to meet and make progress. Professor Renfrew's report will be our main reference document. Anyone who wants to get involved, give me a shout. So that's Maria Heron. That's a nice way to finish. Thank you, Maria. Thank you. That's lovely.
Well done, Maria, and all of your colleagues. That's brilliant.
And thank you, everyone, for engaging so beautifully. I'm sure there's going to be other events, because I don't think we can let Mary escape without going through even more detail. I particularly liked the kind of the 3-level, the result, and then the actual system, because I think that really emphasized that piecemeal comment that you made. No, so I'm going to have to bring the hour to an end and say a huge thank you to Mary for joining us this evening. Thank you also to Angelo, who's behind the scenes making sure this is all recorded. For those of you who want a podcast at 6 o'clock in the morning on Friday, or the recording later on, it will be available after tonight, and especially on Tuesday in the newsletter. Also, thank you to Paul for feeding through the comments and questions to me. Resources are available on the website and Facebook. Next week, we're looking at homelessness in pregnancy in the early years, and we've got Sarah Cummings, Monica Lagan-Paul, Angie Utara, and Belinda Ngugi. I hope I've pronounced that correctly. Find out next week. And in the meantime, say another big thank you to Mary. To all of you, stay safe. We'll see you next week, hopefully, if you enjoyed this session. And do remember, you'll get the recording of this so you can replay and maybe share with your colleagues, because this is not, I don't think this is a research or a report. I shouldn't say research. It's not, it's more than that, isn't it? This report is not just for Northern Ireland, it has a huge potential for our whole maternity services. So do share it and get discussing it and raising it with colleagues. So in the meantime, take care.